Now, the next speaker, I think he's one of the heroes for conserving the axilla. Amit is in Derby in England. He's associate professor and consultant there. And from the days of the ATNEC trial to the ATNEC trial and now the ATNEC trial. So all about conserving the axilla. So Amit, the next 15, 20 minutes are all yours if you want to start sharing your screen. Stefan, you need to stop sharing your screen first so that, yeah, that's great. That's great. Many thanks for that, Stefan. Amit?
Yeah, so I'll just start sharing it. Just hold on.
That's great. You just need a slideshow.
Yeah, can you all see it? Yeah, thanks.
That's great.
Yeah, thanks for the invitation. And I'll speak about the ATNEC breast cancer study and also the collaboration with Endomag and Magseeds. So ATNEC breast cancer study is a UK multi-center randomized study, which we've started recruiting earlier this year. And the key question it's trying to answer is that we know from the previous studies, like the Sentinel study, Judy Bowie's study, the Z1071 study, and the Canadian study, that you can do sentinel lymph node biopsy after neoadjuvant chemotherapy in patients who are node positive to start with. And you can reduce the false negative rate to less than 5% if you actually mark the node and you are able to actually take the marked node out along with sentinel node biopsy. But the question remains is that although you can do it successfully by reducing the false negative rate, now would it actually be appropriate to change your local axillary treatment just based on the response to neoadjuvant chemotherapy? And that's what this trial is looking at. I'm the chief investigator for this study. I'm based at Derby and Burton in UK. The trial infrastructure, it's the largest UK neoadjuvant breast cancer surgical study. It's the largest randomized trial being done in the UK for breast cancer in the neoadjuvant setting. It's funded by NIHR, so it's actually on the research portfolio. So if in the audience, we have a UK audience and they wish to consider this study at their site, the study is fully supported by research nurses. So you get full clinical research network support if you want to set up this study at your site. The sponsor is Derby and Burton, who are my employers. The clinical trial unit, which will be running this study, is the Warwick Clinical Trials Unit. And the key feature of this study is that there is an inbuilt radiotherapy quality assurance. Because there's no point in if the surgeon does not do a clearance, but if the oncologist gives radiotherapy to the axilla, then actually you are treating the axilla anyway. So to prevent that happening, so we have a very strict radiotherapy QA program. So all sites, and I'll be discussing this a bit later on. So the key research question, as I mentioned before, is that can you actually change the local axillary treatment in patients who've had a complete nodal response following neoadjuvant chemotherapy? At the moment, the current practice, at least in the UK, is that these patients who are node positive to start with and then have neoadjuvant chemotherapy, even though they have a complete response, in the UK, the standard in most centers would be a clearance. Very few centers would actually do a sentinel lymph node biopsy post neoadjuvant chemotherapy in these patients who are N1 to start with. To give you a brief trial overview, it is a multi-center randomized study. And the key question, the randomization is, after neoadjuvant chemotherapy, patients who've had a complete response in the axilla, in the nodes which are removed at sentinel lymph node biopsy, they will be randomized to standard axillary treatment or no axillary treatment. Now, if the patient is randomized to standard axillary treatment, we leave it to the center to choose between a clearance or radiotherapy to the axilla. The way I see it working, at my own site, for example, we have recruited a few patients now, is that most patients who who are randomized to axillary treatment will actually go for radiotherapy to axilla rather than going back for a second trip to theater. The reason we included axillary lymph node clearance is in the UK, we have around 20 sites who use OSNA, which is an intraoperative molecular test to assess the nodes. And those sites may prefer, when they have the result in the operating room, they may want to do a clearance rather than go for radiotherapy at a later date. So that's the only reason, because it's a very pragmatic study. We included a clearance or radiotherapy in that. It's a big trial, sample size is 1900. The follow-up is at least 5 years, and the intention is that we at least have a 10 years follow-up. We need 100 UK sites, and the study is open both in the country and to international sites. And I've already mentioned the radiotherapy QA program briefly. I'll just take you through the flow chart for the trial design. And so the study includes T1, T2, T3 cancers, N1, patients who are having neoadjuvant chemotherapy. The recommendation is that the site marks the involved node before the patient starts neoadjuvant chemotherapy. Now, we are not prescriptive about the technique that you use for marking. And again, that is just to be pragmatic. You can use Magseed, you can use black dye, iodine seed, reflector, or whatever your preference is. The key question is that we have training resources for whichever technique the site would like to use, and we will be providing training to those who want it. And we can offer, we also offer mentorship for the first case if needed, both for the surgeons and the radiologists. So after neoadjuvant chemotherapy, the study requires that the axilla be assessed by some kind of imaging technique. It can be an ultrasound. Some people do a CT, PET scan, MRI. It's up to the local site. And then the patient has breast surgery, sentinel node biopsy, and the protocol requires the surgeon to remove at least 3 nodes. Now, you can use a single tracer if you're marking the node. But if your site is not marking the node, you can still participate in the study. So marking the node is not mandatory. It's not an exclusion criteria, but it's recommended in the study. So if your site is not marking the node, you can still participate. You do a dual tracer sentinel node biopsy, and the surgeon takes at least 3 nodes out. The patient will still be eligible for randomization if there are no nodal metastases, as long as the pathologist sees a complete response in at least one of the nodes. Because if you're marking the node, the reason for marking is just to tell us that there was cancer in the node, this node to start with, and the chemotherapy has killed the cancer. So what better way than the pathologist telling you that actually they can see signs of downstaging? And that's the reason we put this clause in the protocol, that even if you're not marking the node, we will accept if at least you have taken 3 nodes out and the pathologist says there is complete response in at least one of the nodes. So the randomization is to either axillary treatment or no axillary treatment, as we discussed previously. If the patient is found to have residual cancer in the node, then you can do standard treatment at your center. It could be clearance, it could be radiotherapy, but we will still collect the data for these patients. Because the other question which has not been answered till now is micrometastasis or isolated tumor cells after neoadjuvant chemotherapy, do they actually have the same relevance as macrometastasis? At the moment, if you look at the WHO staging, they seem to suggest that even if you have isolated tumor cells, it is chemo-resistant disease, so the standard should be a clearance. So in this study, we'll actually gather data to answer that question as well. The primary outcomes are disease-free survival and lymphedema. For lymphedema, we are using a patient-reported outcome rather than a clinician-measured outcome, because from my past experience in various trials like the ATNEC, POSNOC, I think the key thing is what matters to the patient, not what matters to the clinician. So we're using the LBCQ questionnaire for that. The secondary outcomes, I'll not go into detail, but they are the standard outcomes you would expect in any cancer trial, which includes health economic assessment, a qualitative evaluation, if there are any recruitment issues at the start, to identify them and then to resolve them as well. The inclusion criteria of the study are very pragmatic, because if you need to conduct such a study with 1,900 patient sample size, being restrictive, I don't think the study will reach its target accrual. So the inclusion criteria are very pragmatic. I'll not go through them. I'll just give you a moment to read them on the screen. I'll just mention that a single tracer, SND, for example, if you were to use mag trace only, that is fine for the study, as long as you mark the node. So that is accepted. So dual tracer is only compulsory if the site is not marking the node. Exclusion criteria, again, they're very standard exclusion criteria you would expect of this kind of a trial. The key criteria, which I've highlighted, is, again, just to remind that if you're not marking the node, or for whatever reason, you mark the node, but you did not retrieve it at the time of surgery, then what? Even then, the patient will be eligible for the study, like what I discussed before, if the pathologist sees signs of downstaging in at least one node, because that tells you that at least the chemotherapy has worked and has killed the cancer in this node. So we would accept that. Now, coming to the radiotherapy QA, we have a very comprehensive radiotherapy QA program that is run nationally for this study. Before the site enters the study, the site will have to fill a facility questionnaire. There's a benchmark case, planning case, and even on the trial, all the radiotherapy plans will be reviewed to make sure that the oncologist is actually not treating the axilla when they're not supposed to in patients who are randomized to no axillary treatment. Coming to marking the node, I'll touch on this because that's a very important or key point in the study. The node can be marked by using any technique. Whichever technique the site chooses to do, we will be conducting training workshops and train the site. The key thing for English sites in England, is that they can get the cost for marking reimbursed locally from their CCG. So if you're looking at participating in the study, cost is not an issue to buy the marker for the node, whichever you like. The reimbursement for marking the node is around 275 to 276 pounds. Current status for this study, we opened to recruitment earlier this year, and we are 6 months behind schedule because of the pandemic. But I think, considering all circumstances, I would say that we have done very well to start the study. We already have 7 NHS trusts open. That includes major sites like Royal Marsden, we have Royal Free, and our own site. Aberdeen is open, which was one of the first sites to have site initiation. We already have 2 patients randomized, and 8 are already registered. And 10 centers have finished the radiotherapy QA program. We already have 80 centers who have signed up to the study and will be open later this year. By the end of this year, we are hoping to open all 80 centers. And the key thing for this study is that we have a collaboration agreement with our industry partners, for example, Endomag. They have been very supportive for the study. We have an agreement in place for Endomag to support us in conducting the training workshops, which will be held later this year, pending restrictions lifting off. So we will be conducting regional training workshops to train people in different techniques of axillary node marking. And we also have an agreement with Endomag, and we are thankful for their support in agreeing to provide Magseed free of cost if the patient goes in the ATNEC study. I think that will help in collecting the prospective data and the long-term data of marking the axilla or marking the node so that we can compare different techniques. We have Australia and New Zealand who are interested in opening the study. We are just awaiting the funding decision from NHMRC. We have expression of interest from Romania and Greece, and we are looking at the feasibility and logistics of opening them. So marking the node, I'll touch on a few techniques. The black dye technique, I'll touch on that a bit because we did a study called the pre-ATNEC study before we started the ATNEC study. The advantage of the black carbon dye is it's cheap. In the UK, it costs around £10 per syringe. And the multi-center study that we did and published in breast cancer research and treatment, it showed that there's no learning curve for surgeons or radiologists. The identification rate does not change with BMI or volume of injection. Learning from our study, the multi-center study, we are now able to standardize the technique. One thing we learned, which is very critical, is the volume of injection. We need to inject only 0.2 to 0.4 ml. So if it's a small node, 0.2 is enough. If it's a large node, 0.4 is enough. My recommendation is, from experience, do not inject more than 0.4 ml. And you do not need to inject, again, that's a learning from our multi-center study. You do not need to inject around the node or in the tract, because that makes the life of the surgeon difficult. The surgeons in the multi-center study, we captured the data. They found that whenever we injected around the node or the tract, the whole axilla became black or gray, making the life difficult. There are some training videos. I've shared the links on this slide. They're free. So if anyone would like to learn the technique, the videos are self-explanatory. And we'll come to Magseed now. Magseed, again, very promising technique. And we are thankful for their support. They're coming up with a new marker, which hopefully will have less interference with MRI scan, which is very important in neoadjuvant patients. The current marker measures 1 millimeter by 5 millimeter. And these pictures are courtesy of Endomag. Thanks for them. So on the right-hand side, you can see the Magseed in the node. And the middle picture just shows a comparison of the size of a rice grain with Magseed. I'll just play this. I'll try to play this video. Again, it's courtesy Endomag. Sorry. Sorry, I think I'll go to the next slide. Technical issues again. Yeah. Now, I was looking at Magseed. I mean, we've listened to extensive series now, but these are the two pathways which come to my mind. So if you want to use Magseed, you could mark the node. If you look at the top one, you could mark the involved node before the patient starts neoadjuvant chemotherapy, and then, which makes your life easy for the surgeon. The surgeon can do sentinel lymph node biopsy and remove the marked node using Sentimag. Now, if you're worried that this patient has an upper outer quadrant tumor, and you're potentially going to monitor this using an MRI scan, and the MRI artifact will be an issue, then I think the second pathway comes to mind is that you can actually mark the involved node using a standard clip before the patient starts neoadjuvant chemotherapy. And then after neoadjuvant chemotherapy, you've already assessed the response to decide whether you are able to offer breast conserving surgery or not, or to assess, or to make your decisions, which are dependent on the tumor response. And then you can mark the clip or the clip node using Magseed under ultrasound guidance and carry on with your sentinel lymph node biopsy and removing the marked node. So just to conclude and summarize, I think for patients who are node positive to start with, and they convert to complete response in the axilla, we know that the false negative rate is less than 5% if you mark the node and remove the marked node along with sentinel node biopsy. But what we don't know is whether we can change local treatment to the axilla based on response to neoadjuvant chemotherapy. An ATNEC trial specifically addresses this question and will give us data from randomized study, which will change clinical practice in this country and hopefully around the world. ATNEC, the other opportunity is, especially in the UK, because the standard treatment still for these group of patients is clearance, and very few sites actually mark the node and then do sentinel node biopsy and removal of the marked node. ATNEC trial provides an opportunity to actually adopt the technique because we have the training resources which we will provide to the site and also mentorship. And also because with the collaboration with industry partners like Endomag, you will be able to get Magseed free of cost if you put the patient in the study. So in the long term, ATNEC trial will also be able to answer the question on the outcomes of different marking techniques. And lastly, I think Magseed provides a reliable way to mark the node if that's your preference. And for ATNEC study, as I mentioned before, this is free of cost, thanks to Endomag, if you participate in ATNEC. Thank you very much for the opportunity.